My talk, which is the only thing that stands between us and lunch, promised to be on time about. Um, there hasn't been a lot of new updates on the forefront for the M0 patients, the non-metastatic patients, but I'll kind of update you on some of the follow-up data that has come forward from the Sentinel trials. These are my disclosures. And this is just the outline, but we're going to talk a little bit about that patient selection, which is an important consideration, talk about the trials that led to, and then the guideline recommendations that are there. It was mentioned earlier, but I think it shouldn't be overstated that we know prostate cancer remains the #1 cancer in men, and it's the second leading cause of death, unfortunately. In the newly diagnosed men, though, that are being seen, there's been, since about 2014, about a 4 to 5% increase in the discovery of advanced disease at diagnosis. And so this, unfortunately, the goal of this would be like this course never needs to take place because we catch everybody early and we treat them and they're done. But that is not what's going to happen given what is in the, the controversies around screening, the access to screening and primary care attitudes and U.S. Preventive Task Force, which I think is going to change. But we've got a lot of work to do, but advanced prostate cancer is not going to disappear for the foreseeable future. So it's important for us to know about all the ways we can manage this. Now, what about these non-metastatic CRPCs? And, it's true that the trials, and we'll talk about that, didn't really have PET scans, but even with PET scan, you don't catch every lesion. You can't see everything that's out there, and it certainly doesn't capture circulating tumor cells. There's certainly rationale for catching things when the burden of disease is lower. We have talked already many times today about the benefit of moving therapies up earlier. So at our table a few minutes ago, we talked about the original docetaxel trial and castration resistance, 3-month survival benefit, and everybody yawned. It was like, what is that? And nothing. But it moved into the earlier state, and we had 12 to 18 months benefit over ADT alone, which we thought was the best thing we had. So not only moving things earlier, but intensifying has shown benefit. And the truth is, once you have metastatic castration-resistant disease, it's lethal. And so delaying, preventing, anything we can do to keep them out of that state is certainly worthwhile. So we have a window of opportunity. How long will that window stay open? We are kind of embarrassment of riches because we had 3 novel hormonal, we call them second-generation anti-androgens that have been well described by Dr. Gerard today. And there was a period of time when we had nothing in this space, so the mechanisms of action has already been discussed, but there's 3 different ways in which they work, but they're often quoted to be 10 times more potent than what we used to have when you think about like bicalutamide. So that's good. We have some medications we can direct at this. Risk assessment, again, referred to in Dr. Borshen's talk earlier, but in both the non-metastatic castration-resistant and the non-metastatic hormone-sensitive, the PSA kinetics tell you something. And we know that patients that have slow doubling times can often be observed, and it's recommended. But in patients, once that doubling time gets into the 10-month, 8-month, 6-month, the development of a metastatic site is common. And this was gleaned out of trials looking at like denosumab and bone health and things like that, where they were treating the bones, but then lo and behold, the doubling times predicted the development of these metastatic sites. So we learned things, even though the drugs themselves may not have moved forward in terms of treatment for disease in this setting. So doubling times are important, and they predict the metastatic event. So the guidelines recommend calculating those doubling times when you are following patients who simply have a rising PSA in this setting. And now, as Dr. Stratton pointed out, incorporating, if you have available to you, PSMA PET into the staging instead of just conventional imaging is important. Unfortunately, those weren't in the trials that were for the approval of the agents in this space, but those patients were out there, and there were European patients that had PET scans with some findings on them. But in general, if possible, PET scan is an option. And then the following sequence is somewhere in that 3 to 6 month range, as well as imaging about every 6 months to try and capture if they are going to progress in that setting, given that these patients are usually pretty nervous and fixated on their PSAs. So this is our 8th year of doing this course, this combined course, but there was a period of time where this lecture was just full of nothing. It was a data-free zone. It was like, what do you do? And people did everything, but there wasn't really any evidence behind it. So luckily, and fortunately for us, the FDA said, we're going to allow for a shorter endpoint, because it's really hard when you try to think about the natural history of some of these patients. They may live a long time. And so you had to come up with a surrogate endpoint, if you will, the metastasis-free survival. And they believed it was important, and they used it to allow for trials in this space. Otherwise, we probably wouldn't have had the approval for a long time. So at that time, though, it was really novel. It was a new endpoint. Everyone believed that it was meaningful, both from a clinical standpoint and patient standpoint, and nobody knew the impact on survival at that point. So there were 3 studies that had very similar trial designs. So I won't go into great detail on each one of the designs, but basically they're randomizing patients who have castration resistance, rising PSA, no evidence of metastatic disease on conventional imaging, and then they randomize them to the treatment of the novel hormonal therapy or placebo while continuing their hormonal therapy. And so alphabetically, apalutamide. So this was their study design, again, randomized on a 2-to-1, because patients need a little enticement to be in the study. If it was just 50-50 chance, maybe they weren't as interested. So 2-to-1. They were allowed to have some small volume lymph nodes. To get into the study, I think their PSAs were elevating, and then they had to have that doubling time of less than 10 months. And you're going to see that consistently too. So the companies that did these studies weren't stupid. They didn't want to have the patients with very slow doubling times. It took forever. They would never complete their study, and they may not have needed the treatment. So they enriched them with patients that were likely to develop metastases. So that's the way that it was designed, with the primary endpoint of MFS. So the median doubling time was around 4.5 in this study. 60-70% of patients had doubling times less than 6 months. So this was the Kaplan-Meier curve, showing significant benefit in terms of metastasis-free survival, which was not only development of metastatic disease, but also death. So that was important. These AE side effect profiles are listed in your handout, so I won't go into great detail, but we all know that these medications have some fatigue, hypertension associated with them. This particular one had an associated rash that was mentioned earlier. So you got a rash, then nobody knew what to do at the beginning, and people stopped therapy, but in the practice during the studies, they evolved into holding it and then restarting it, and it appeared to resolve itself. But rashes were unique to this apalutamide study, and also under these other interesting adverse events, the hypothyroidism was found in a small percentage of people, but in patients on apalutamide, it's recommended to follow their thyroid functions, get baselines, and then periodically follow them. So this is the Kaplan-Meier curve, but again, I show for emphasis that this was like 20 months of metastasis-free benefit over placebo alone. And then because these are asymptomatic patients, other than their hormonal therapy, it's important to know what's it going to do to their quality of life, and their quality of life appeared to be maintained based on these patient-reported questionnaires. And then subsequently, a couple of years later, the data got reported in terms of the overall survival. And so that was good news, because the medical oncologists really didn't get very excited about metastasis-free survival. Urologists were pretty comfortable with it, but it was like at meetings you would see almost no buy-in from med-onc and a lot of enthusiasm from urologists. But at least there's overall survival now. So I don't know. We never did a post hoc questionnaire on this, but I think that was very important for us to see that there was by a little more than a year. The second study that I'll present is the darolutamide results. Again, you're going to see commonality with the trial design, 2-to-1 randomization, same primary endpoint, enriched because the patients to qualify for the study had doubling times of less than 10 months. Here, the median PSA for enrollment was around 9, so many of our patients probably wouldn't wait that long these days. And then you can see the doubling times were around 4.5. median on average, and then a high percentage, like 2/3 or more, had doubling times of less than 6 months. And look, it's identical, right, to what you saw before in terms of the split and separation of these Kaplan-Meier curves, with highly significant separation for the metastasis-free survival. The AEs, again, are similar. And I always want to caution people, because they ask sometimes, like, can you just take these charts and superimpose them on each other and figure out, like, who has the most AEs? And the answer is no. The trials are designed to have different questions asked, more emphasis on some or the other. And of course, they're not in a randomized fashion. So it's not appropriate to say, well, this one had more hypertension than that one. That's not a comparative type of situation. So don't want to fall into that pitfall. But the usual class effect of things such as fatigue, falls, and that sort of thing were listed in there. Small percentage of rashes, but not as much as what I showed you in apalutamide. Again, not comparative. But I think when we see rashes now in patients on these drugs, we often know to consider that as the etiology. Again, quality of life maintained, and actually staved off some urinary and bowel-related symptomatology through the use of the treatment. So that showed kind of a improvement, because there was deterioration in the placebo arm. And then very similar to what I've showed for the first study, the metastasis-free survival events were in that 20-month range comparatively, and that translated later publication into overall survival. So it's encouraging, because we have other studies ongoing where metastasis-free survival is a primary endpoint. Whether they'll always translate into overall survival is not known, but at least in this situation, they did. There were other secondary endpoints, I won't belabor them, but like need for cytotoxic chemotherapy, symptomatic skeletal-related events were also improved by the use of the therapeutic agent versus the placebo. And then the third trial, enzalutamide, was the PROSPER trial. A similar trial enrollment, PSA doubling times of less than 10 months, randomization 2-to-1, rapid doubling times as were included in the other two trials. Very almost superimposable type of metastasis-free survival benefit demonstrated in the trial. The AEs are listed there, and you can see them. There were a very small number, but there were 3 deaths, I think, in the enzalutamide group, and I think a single death in the placebo. I can't remember if they ever totally reported those. May have been cardiac, but I'm not 100% sure. The usual side effects, hypertension, of course, is seen in some. So the need to, it was mentioned earlier, a lot of these patients, before they undergo any other hormonal treatments, are recommended to get a cardiac evaluation. And if you have that option, we should check in their lipid profiles. There's a whole nother discussion about just ADT alone and its impact on the heart. But in general, if patients are seen by a cardiologist and are monitored under their care, they're less likely to have a major cardiac event, and that could be worsened by the use of ADT. The metastasis-free survival curves were, again, reproducible compared to the other trials. So we know that this is an expected goal of therapy to reduce the development of metastatic disease using these agents. Their quality of life was stable to improved compared to the placebo, so important again. And then overall survival on a subsequent publication was there for these patients as well. So this is a meta-analysis that put those 3 trials together. Sometimes when you look to level of evidence, you want a randomized trial of good quality. Then, of course, a higher level evidence would be combining multiple trials of reasonable quality. And that's what you get from a meta-analysis in this setting. And for metastasis-free survival, for progression, and for overall survival, the curves are all favorable for the treatment. So what do the guidelines say then? Clinicians should offer apalutamide, darolutamide, or enzalutamide with continued ADT in the non-metastatic CRPC patient at high risk for developing metastatic disease, and that was defined based on the labels of the trial, not based on the trial, at PSA of less than 10 months. Clinicians may recommend observation with continued ADT to non-metastatic CRP patients, particularly those at low risk for development, and that's the longer doubling time, so greater than 10 months. I think one of our original questions was a patient with a very slow doubling time where surveillance would be certainly appropriate. And then to date, really no role for cytotoxic chemotherapy, immunotherapy yet in this type of patient. So in summary, patient selection is important in the M0 CRPC patient. The FDA approval was based on the metastasis-free, but we now know that not only was there that, but overall survival for those patients with a rapid doubling time. Men with longer, slower doubling times are appropriate for consideration of observation and delaying therapy, and quality of life appears to be maintained when those agents were used. So you have 3 randomized trials that were presented, all demonstrating that benefit. Of note, the FDA approval for these agents doesn't really prescribe any strict PSA doubling time, so that's our guideline recommendation based on how the trials were designed, but it's not how the medications were approved. And the decision whether to treat a patient or not always is going to be based on combination of factors, including shared decision making, their goals for how to delay the onset, economics, etc.